Good evening. Thank you very much, Professor Bahbah and the Boss Zanoun, for the very kind invitation for your awaiting event yearly. I would like to introduce Professor Zubaida Masoud, pediatric nephrologist, who is going to talk to us about acute kidney injury in children. Let us stop the impact. I'm personally waiting.
السلام عليكم. بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. First of all, I'd like to thank the organizing committee for giving me the chance to come to this very prestigious Congress and also to have the opportunity for the first time to visit Egypt. So I will start my presentation. Is this better? Can you all hear me in the back? Okay. So I will be talking about acute kidney injury and how we can prevent or at least, minimize the impact of acute kidney injury in children, particularly in hospital setting. So why do we need to talk about acute kidney injury? So acute kidney injury is a catastrophic, life-threatening event, especially in critically ill children. And the incidence of acute kidney injury in hospitalized children have been significantly increasing, particularly that with the advanced care that we're providing our children, we are seeing more and more even secondary causes than a primary cause. The incidence in general population is around 0.8%, whereas it is like 4% in critically ill children, and overall admissions is around 0.5%. If you go through the literatures, especially maybe about 10 years ago, or even a little bit more, the incidents were completely different, depending on the study, but more and more with the new definitions, as I'm going to talk about them shortly, we start to have more, unified incidence of the disease. So this is one of the study, Ahmed Qaddoura. He did a multinational prospective study in pediatric intensive care unit to define the incremental risk of death and complications associated with severe acute kidney injury. He found that around 27% of patients developed acute kidney injury in the ICU, and about 11% of them had severe acute kidney injury requiring dialysis. And also he realized that assessment of acute kidney injury using plasma creatinine level only failed to identify AKI in very large portion of patients, so 67%. So they were able to identify those cases for other findings, as talking about early diagnosis. In another study, Mike Zapitelli evaluated 500 patients patients who are sick and were admitted requiring aminoglycoside, which is one of the nephrotoxic medication. And they found that 33% developed acute kidney injury with a criteria called P-rifle. I will describe that shortly. And 20% using the other criteria, which is AKI and Acute Kidney International Network definitions. The AKI developed by these two criteria were independently associated with long hospital stay and also increased total cost of the hospital. In pediatric intensive care unit, AKI is an independent risk factor for mortality, longer length stay, and also longer duration of ventilation. Small children, or a small change in serum creatinine will have a significant renal insult. Minimum serum creatinine in children is associated with significant risk of mortality and morbidity. And finally, worsening fluid overload is an independent risk factor for mortality. Children with acute kidney injury are at risk developing chronic kidney disease in the future. And the impact of acute kidney injury, this is another study that evaluated an impact of acute kidney injury as a long term, and they found that 33% of survivors had reduction in their GFR and proteinuria, and 73% of them remained hypertensive. Also, it was found that the patient with more severe renal impairment on admission, they had higher rate of mortality. With that, I think we really have enough reasons for us to self-aware or to aware ourselves about, how we can prevent acute kidney injury in children, and also maybe at least minimize the impact of it. So within the next 20 minutes, I hope that I will talk a little bit about acute kidney injury definition, which I think is the most important step, because if we don't define it, if we don't recognize it early, then we won't be able to prevent it or treat it. Quickly, we'll pass through the common causes and risk factors, pathophysiology, management, renal angina in pediatric AKI. It's a very new concept. I'm just going to highlight on it. And then finally, what can we do to our patients? So acute kidney injury is a reversible increase in serum creatinine and nitrogenous waste product. It's an inability of the kidney to regulate fluid and electrolyte homeostasis appropriately. Many people used to define it in a different way. It could be anywhere from increase in serum creatinine to being anuric or oliguric, or sometimes to require dialysis. Serum creatinine, which is the common or the gold standard of defining acute kidney injury, along with the urine output, it's still not ideal, and probably everybody knows that since medical school, but we're still stuck with it until now. It is a late markers of the injury. Usually it requires more than 50% glomerular damage to be able to start appreciate it in the serum to say that there is, so that's a really big damage to the kidney. And it can be difficult sometimes to predict because there are many other confounding factors, like example, the size of the child or muscle mass. As I said, and also children with the decreased muscle mass, as I said, sometimes it will underestimate the incidence of acute kidney injury. So despite encouraging results in many animal studies that are talking about treatment of acute kidney injury, most of these studies, they're doing their studies so they would clamp the kidney or induce acute kidney injury, and they will give treatment very early, and these treatments are really promising. And the age of these treatments, some of them goes, up to 20 years. But the problem we are stuck on, we still don't have a very good, markers that will reflect this early stage of acute kidney injury so that we can implement it in human. And so if I will show you how the creatinine raise. So if you have an insult at time 0, either for somebody who has, severe dehydration, sepsis, or cardiac patient or any patient who undergo major surgery. So basically, the insult starts at time 0. At that time, there is inflammation, apoptosis, lipid peroxidation. Then you start to have tubular cell death within the 24 hours. And then finally, 48 hours later, you start to, appreciate the reduction in GFR reflected by an increased serum creatinine. And that's what happened always. So patient comes sick. After 2 days, you start to realize that there is an increased creatinine, and we call nephrology, which is considered to be too late to act on it. So what is very important is to have novel markers that raise really few hours after that injury, so I can prevent and I can treat that injury. So many studies, as I said, have been for years now using genomics, proteomics, metabolomics to evaluate urinary proteins that appears very early in tubular cell injury. And some of these proteins are like plasma cystatin C, which is used, but still, you know, we don't have a very good grasp on it. So we don't have an excellent, you know, evaluation of it, but it is used in conjunction with the creatinine. There are other promising markers like plasma and urinary neutrophil gelatinase associated lipocalin, urine kidney injury molecule, and IL-18 with their other interleukins also. So for cystatin C, for example, it is synthesized, released into the plasma by all nucleated cells, freely filters by glomerulus due to its small size, and completely catabolized. So it doesn't go, minimum does secreted in the kidney, in the urine. And it raises within 2 hours. It can start to raise, particularly within the first 24 hours. This is a study, a meta-analysis, evaluating 24 articles that was done for cystatin C, and they found that cystatin C has an acceptable prognostic value for prediction of acute kidney injury, and it usually rises within the first 24 hours on admission in patients with acute kidney injury, and this biomarker can be suitable as an alternative traditional. For the NGAL also, there is many studies. For example, I'm just giving examples of them. So prospective study that was evaluating children who undergone cardiac surgery and found that plasma and urine NGAL measurements increased hours after surgery in those who developed AKI, as of the creatinine, which increased 2 to 4 days later. But for now, as I said, we're still stuck with serum creatinine. So let's talk how we can work with what we have now. So the classification, we have two main classifications for acute kidney injury. We have something called RIFLE, or P, pediatric, P for pediatric, so, and RIFLE criteria, which has risk, I, injury, F, failure, L, loss, and E for end stage. So basically, it talks about GFR function and urine output. So risk is an increase by 1.5 of the serum creatinine, or a GFR reduction of 25. And if you look at it, it's really different from adult, because if you have a serum creatinine of 20 millimole per liter, then 1.5 or 25 increase basically is 30. So if you look at that number, it's not much if you have it as only number. And that's why I'm going to repeat this again. Looking at the trend, going back to what was the baseline is very important. And again, maybe it's not still an injury, but having that R, the risk, that will make me, try to prevent this or minimize the injury if I can. Then you have injury, it is more than 50%, failure, more than 70% increase or reduction in GFR, loss, if you have the more than 70% GFR reduction for more than 4 weeks, and end stage if it persists beyond the 3 months. And then also you have the urine output description. The Acute Kidney Injury Network proposed another small modification, but both of them, in my opinion, can work. So instead of risk, they have stage 1, which is serum creatinine rise between 1.5 up to doubling from the baseline. And then stage 2 rise between doubling to tripling of the baseline, and stage 3 is when you have more than triple, or patient who are on dialysis. Because sometimes patient might be on dialysis due to significant fluid overload and anuria before the creatinine rising. Also, I want to remind you that the kidney start to develop, early on from 5 to 34 weeks. For especially those neonates, if they have a significant insult, that can cause them to have chronic kidney disease, because the glomeruli hasn't been developing well. and the GFR is not normal. It usually reach normal, an adult GFR by 1 to 2 years of age. But again, I just want to remind you, following the trend is more important. So look at the baseline and go from the baseline. Different people, different children will have different baselines. So that's very, very important. Again, here just an example of the values of creatinine. So it really changes, especially in neonatal period. And it might be very difficult for a pediatrician to be able, even for me as a nephrologist, but looking at the trends will help me more to have an idea. So common causes, as you know, as I mentioned, the causes mainly shifted from primary to multifactorial causes because of the development in the medicine and pediatric. But as if we go back to medical school, we're talking about pre-renal, intrinsic, and obstructive. I'm not going to take long time on that, but if you remember, these are pre-renal, and then you have the intrinsic, and then you have the obstructive causes. And this is one of the studies that evaluated the common causes, and as you can see, infection is very common. Then you have glomerular disease, nephrotoxicity, volume depletion, and it goes on. Also, I want you to keep in mind to help you in terms of differential diagnosis. Those patients who have reduced urine output probably more toward hypoxic ischemic insults or glomerulonephritis, while patients who have maintained good urine output, usually they'll have maybe interstitial nephritis from some drug reactions or nephrotoxic medication or contrast nephropathy. Risk factors are very important because they're where we're going to start to prevent this. So critically ill children, we said many studies showed at least 20% depending on the severity of the disease. Patients who are on pressor and mechanical ventilation, maybe up to 80% of them, they will have acute kidney injury. Children who are receiving nephrotoxic medication, at least 20%. If they are sicker, maybe it might be higher than that. Neonate, as I mentioned, also there are variations, but it can be up to 8% because of the extreme prematurity. Maybe they have cardiac surgery or medication for the duct, birth asphyxias, low Apgar score, and maternal antibiotics and non-steroidal anti-inflammatory drugs. So if we collect most of these common risk factors, you have intravascular volume depletion, which is very common. So we might have many kids who come to severe dehydration. We need to keep in mind that these kids might have acute kidney injury. Children who undergo cardiopulmonary bypass surgery, sepsis, kids requiring ECMO, stem cell transplantation, any sort of ischemia, major surgery, but also major trauma, and very, very low birth weight. So with prenatal, if we're talking about that, so patients who have severe volume depletion, their blood flow will be low. And if you look at this graph here, you have the afferent and efferent, if you remember from medical school. So in the afferent, there is a response to reduce the renal blood flow by increasing, by the prostaglandin. So the afferent arteriole will dilate, so we can have more flow to the kidney, to the glomeruli. While in the efferent arterioles, there is angiotensin II, which causes vasoconstriction to keep more blood in the glomeruli. So this is a natural mechanism to protect the kidney during dehydration. In severe dehydration or using certain medication, this mechanism, so this mechanism can be affected. So if you're using non-steroidal anti-inflammatory drugs, for example, you give kids ibuprofen and they're already dehydrated, you're protecting this mechanism. So you can cause acute kidney injury. If patient who has, on angiotensin converting enzyme or angiotensin receptor blockade for any other reason, proteinuria, mild renal insufficiency, hypertension, then with this medication, they will have further injury. Of course, this mechanism will not go on and on. So if you have severe dehydration and you're not repleting it, even without using these medication, at some point this mechanism will stop and the kidney injury process will continue. Also, if we're talking about the intrinsic, so if there is hemodynamic instability, endothelium will increase, nitric oxide will go down. This will cause vasoconstriction, as I mentioned. Also, there is a medullary congestion. All of this leading to tubular injury. The cells that comes from the tubule will block the tubules, causing a reduction in the GFR. So this is just a picture showing what I was explaining a little bit. So how do we manage? There is no effective treatment, as I said so far, but we can improve the prognosis by prevention first, and then also early diagnosis as much as we can. So rapid recognition is very important by having high index of suspicion. We need to correct any reversible causes like SIPs, hypotension, dehydration, avoid any further renal injuries, removing any causes, any nephrotoxic medication that we don't need. And also we need to maintain normal electrolytes and fluids during the acute kidney injury as much as we can. You will say, how I'm maintaining the fluid? It's always by monitoring. So weight, maybe urine output. If the patient is not very sick and you don't want to put a catheter, at least you have to measure the diapers so that you can make sure that you have a good balance. Fluid resuscitation. So early volume repletion to ensure effective perfusion of the kidney. Consider colloid if the patient is septic and not responding to saline. Consider inotropes, especially for those who have distributive shock or cardiogenic shock. Extra careful with congestive heart failure patients. Close monitoring of intake and output, as I said. Again, try to stop these medication, angiotensin receptor blocker or angiotensin converting enzyme. Stop non-steroidal anti-inflammatory drugs, and always I advise my patients not to give it at home and without supervision. So we do tend to give Voltaren rectally or Profene for the high fever, but most of these kids with very high fever, they are also dehydrated. So we need to be careful not to overdo this. One dose can cause injury. And finally, if we really, we try to avoid nephrotoxic medication. If we don't have another option, at least we need to closely monitor it. And the last thing, in case especially it's not very clear the cause, maybe you need an early kidney biopsy in order to identify the cause and give a proper treatment. Remember, polytrauma, what happened is patient come very sick, probably fractured femur, lacerated liver, and the trauma team do their best to treat this patient. By the time, after 48 hours, when the patient is stable from these major trauma, you start to see an increased serum creatinine because the patient has rhabdomyolysis. So it's very important, just anticipate trauma patient, then I need to make sure well hydrated, I need to make sure that maybe the urine is alkalinized to prevent the injury. So when do you do dialysis? If there is rapid increase in serum creatinine, persistent anuria, significant weight gain, and maybe refractory hyperkalemia, severe hypocalcemia, hypophosphatemia, or persistent worsening in renal function. Renal angina, quickly, it's a concept that came from the cardiac angina where they have cardiac enzymes, they have a particular risk factor patients who, in terms of age, for example, hyperlipidemia, they use these enzymes to say if this patient has, myocardial infarction or not. So this is a concept that have been, nephrologists are trying to come up with and able to have a criteria to know who are the risk factors. And these are basically factors, as the risk factor that I talked about, and then also in terms of fluid, urine output, and change in serum creatinine. They have scores. It's not still used, but I just wanted you to know that it's something that hopefully is going to come soon. And some of the studies already showed positive findings with that. So finally, what can we do now for our patient? Please think about the kidney whenever a patient comes to the hospital sick. So have high index of suspicion, identify risk factors, ensure good renal perfusion. Okay, it's the last slide. Monitor serum creatinine, monitor intake and output, monitor body weight, avoid these nephrotoxic medication if possible, and thank you very much. I'm sorry for taking a long time.
Thank you very much, Dr. Zubaida, for the very nice elaborating and comprehensive lecture. Do anyone have questions? Okay, thank you.